This is the fingolimod, also called Gilenya. This is the first oral drug approved, I don't know, December or something, late last year. So this is one of the studies. There's actually 2 phase 3 pivotal trials done. This is the FREEDOM study, looking over a 2-year period of time. They had studied 2 doses, a 0.5 milligram, which is a dose that was approved by the FDA, and a 1.25 milligram compared to placebo. And what you can see is, again, there's about a 55% reduction in relapse rate of people on drug, and that is good. So to compare that to, say, Betaseron, Rebif, Avonex, and Copaxone, those drugs are in the 18% to 30% range, Avonex being 18%, all the other drugs being around 30, 32%. And so this is a significant improvement. Also, the probability of having increased disability over 2 years, as we measured in a certain test that we do, was reduced by 30% by this drug, whereas, again, the interferons and glutaric acetate have around a 10 to 15% treatment effect in that area. Yes?
You're just talking about clinical observations. What's happening in the brain's MRIs with those drugs?
So the question is I'm talking about the clinical data, what's happening in the MRI in the brain, what's going on in the brain. This drug has about an 80% reduction in the number of new lesions forming in the brain. Natalizumab or Tysabri has about a 90% reduction. Copaxone is around 60%. The interferons are hard to interpret because the MRI overestimates their clinical effect, and because we tend to measure the breakdown of the blood-brain barrier, and interferons tend to fix that, but they don't prevent the injury in the brain as much. So they'll have about a 60 to 80% reduction in MRI disease activity as measured by gadolinium enhancement, which is where they give you that intravenous dye and it lights up the areas that are active. But their clinical effect is only around 30% reduction in relapse rate. And the other thing about these studies is that in these studies they actually did measure a decrease in the loss of brain volume in these patients, which we had a hard time seeing with the earlier generation of drugs. We could see it with Copaxone, but we couldn't see it with the interferons, or just barely. So,
you see it with the Tysabri.
Yes, Tysabri also has a protective effect on the brain and preserves brain volume. It doesn't seem to completely stop the decrease in brain volume over the time. The problem is we didn't compare it back to healthy control, so we don't know whether, there's a delayed, in fact, if you treat with an immunological therapy and you shut off the inflammatory attack, it may actually take months to years before the secondary effects of that on the nerve cell population will actually work their way through. The reason is if you kill one nerve cell, that nerve cell dies. But that nerve cell is connected to other nerve cells, and it's firing those nerve cells, or those nerve cells are firing to activate that cell. And the brain is built that if you don't use it, you lose it. And so nerve cells that are not connected will ultimately be deleted. So you get a network effect. So you knock out one part of the network, the whole network may die off over time. And so it may take a year or two for the full effect of the immunological therapy to be seen. We haven't done the right kind of studies to really be able to see that. So most of the MRI studies looking at brain volume are only 2 years long. We really need to look as a year 2 to maybe year 5 and see whether that then begins to match what we see in the healthy controls. Any other questions about that? Okay, can I next slide? This actually gets to your question a little bit, well, actually not quite so much. This is actually looking at disability. And the point I was making about this particular slide is this using a scale called the Expanded Disability Status Scale. And it's a very insensitive, sort of lousy scale, but it's the only one the FDA recognizes. And if you look at placebo patients, they're getting worse over the 2 years of the study. But the patients on the drug, on average, if you looked at their average score, they either stayed the same or got slightly better. Now, this is a hint in the fingolimod study. We haven't yet proven it by post-marketing studies. Those are underway now. But it has been proven with Tysabri or natalizumab. So there's at least 15 reports now in the literature from all over the world that if clinical groups monitor patients on Tysabri, and let's say they monitor 100 patients, they look at cognitive function, vision function, motor function, balance, even employability. On average, patients on that drug are actually improving as a group. It doesn't mean everybody in the group is improving, but it means that the majority are. And that's what we see clinically. So in the clinic, and you certainly talk with Dr. Corboy, Dr. Mervale, or Dr. Bennett about this, but we all have the same anecdotal experience, is that the days that we're seeing patients on Tysabri coming back are very easy days by and large for us. because patients, by and large, after about 6 months, are much more likely to be stable, and they're much more likely after a year or so of telling us that they're actually better now than they have been for years on the drug. And in patients that are newly diagnosed, that are in the first couple of years of disease, it's not uncommon to come back and say, I feel now like I did before I got MS. We never heard that on the interferons and glutamer acetate. And so this is a real shift in our experience in the clinic, and it sort of validates what we're beginning to see in the clinical trials. But to get that, we're paying a higher price in terms of side effects and risks. Can I have the next slide? This is just a chart I made up to try to compare the drugs, and I've not put on here laquinimod and BG12, mainly because the data has not been validated yet in peer-reviewed publications. But if you look at relapse rate reduction, which is the classic way to do a study, and it's reasonably comparable across studies, what you can see is that as we look at newer drugs, they tend to get more and more effective. And we're moving from about the 30% range up to the 68 to 70% range. And that's encouraging. And the same is true if we look at disability. We're getting better results than we've had before. I've actually got to come off with that. And the same is true for MRI disease activity. And also on brain atrophy. The newer therapies are having more obvious effects on brain atrophy. Now this is ease of use, and this is just my scale. It has to do with the tolerability issues, pain from injections or trouble taking a pill, the number of laboratories you have to have, the number of MRIs you have to have. So it's sort of the burden that patients undertake to use one of these therapies. And the point of this is, it's just that natalizumab being once-a-month IV infusion, when we do studies and we ask patients, to rate these various modes of administration from once-a-month IM to daily sub-Q to once-a-month IV to oral, once-a-month IV is not that much different than oral for most patients. And particularly if you have to take it more than once a day. So if patients have to take a drug 3 times a day, which they will with BG12, that begins to be as much of a burden as getting an IV infusion once a month. So the ease of use of the drugs has actually improved a bit. The exception is alemtuzumab here, and the reason for that is you have to have monthly blood tests on it because of this problem, its safety profile. It has a worse safety profile. So now I've looked at the risk of serious adverse events, and I've used Copaxone as the comparator because it's the safest drug that we've got. And so if you use that as a 1, then the interferons, they do have a risk of suicide due to worsening depression. They do have a potential risk of liver problems, things we don't see with Copaxone, so I would rate them 2. With natalizumab, because of the PML issue, that would be level 4, because about patients overall in a year 3 will have about 1 chance in 1,000 of developing PML, which can be fatal or seriously disabling. However, there's a blood test now that identifies patients who do not appear to have that risk. And in those patients, the safety profile is somewhere between 1 and 2. It's actually back down here. So that's something that's going to change probably later this summer when that test becomes commercially available, if it does. Alemtuzumab has risks of inducing other autoimmune diseases and infections and secondary cancers. So right now, the drugs coming out is the most dangerous. Cladribine, as I said, is not going to be approved because of the cancer risk rates of it. And then rituximab, actually the ocrelizumab data makes it comparable to interferons, and so, but it's far more effective. So this drug, I think, is very, very interesting. There's a question back there.
Yeah, on the PML test, is it possible that you don't have the virus and then can contract the virus?
Yes, good question. The question is if you have a negative blood test for the PML, which is a testing for antibodies to a virus called JC virus, is it possible you become positive? You can become positive in 2 ways. One is that with every laboratory test, there's what we call the false positive and false negative rate. It's just the error built into the system that if you do a certain number of tests, one is going to be wrong just due to chance. And the error in this particular assay, that error is about 2.5%. In addition, it turns out about 3% of us every year are getting this infection. We don't know exactly how it's transmitted. We know that sewage is 100% positive for this virus, so we assume it's a fecal-oral route, but it's actually never been proven. So about 3% of people will convert from negative to positive because they do get the infection every year. So if you're on Tysabri, my view is you need to get that test every year, and that information needs to be used. And in fact, it may be that the fingolimod and cladribine, or certainly cladribine, alemtuzumab and rituximab, not rituximab so much, but alemtuzumab, these drugs may also have a PML risk. We just don't know yet because there hasn't been enough patients exposed. The reason I say that not rituximab is that rituximab is an old drug used for rheumatoid arthritis and lymphomas and other things. There's been 2 million people exposed to this drug, and there's not been a single case of PML in people who are on monotherapy with rituximab, which is the way we use it in MS. There is PML when it's used with other chemotherapies, but those chemotherapies are known to cause PML on their own. So this drug seems to separate the PML risk. So that may be in the future. Yes, ma'am?
What's the 3 for the Galenis? What's the 5, what's the?
Okay, so the question is, what's the 3? Why would I label 3 for galenium? So galenium is a new molecule that activates a set of receptors called sphingosine 1-phosphate receptors. Those are receptors that have not been targeted in medicine for any other purpose. The drug's actually been around for a while. It's been tried in transplant, in areas of transplant and other things, but it failed to have an adequate safety and efficacy profile there. But the reason that that's important is that means we don't have a lot of experience with it outside of our clinical trials in MS. And the sphingosine 1-phosphate receptors are actually widely distributed in the body. They're present in other tissues other than just the immune system in the brain. And so, as a result, the risk profile of Gilenya is that it can affect the retina of the eye and can cause macular edema, which can lead to vision loss. So you have to have regular OCT and visual exams with it at least every 3 months. It can affect the heart, can lead to heart block. So we have to do EKGs, make sure you have no abnormalities of heart conduction before we start this drug. For patients that have a tendency toward asthma or COPD, it can worsen that, can narrow the airways and worsen asthma. It does suppress the immune system. There's a 5% increased risk of infections overall. In the studies, there were 2 deaths, one due to encephalitis due to herpes simplex virus 1, and one due to disseminated chickenpox. Now, in both cases, there were other reasons why those patients might have gotten that disease, so we don't know for sure that the drug contributed. But based on its mechanism of action, it wouldn't be far-fetched to expect that to be one of the potential complications. And then the final one is that in one study, there was an increased number of cancers in the treated group versus placebo. In the second study, they were exactly the same. So there's ongoing concern of whether the drug may have an effect on cancer, particularly skin cancer and particularly melanoma. We just don't know yet. And so patients on this drug, we get skin exams for a baseline, recommend they get it every year. So because of those risks, those are higher than we see with interferons, and Copaxone has none of those things. So it's at least a 3, and some people may argue it's a 4. I would say right now we don't know whether it's a 3 or 4. And that's one of our concerns. That's why we tend to use it in patients who have aggressive disease and have failed other therapies, or patients who have been on Tysabri and are antibody positive for the JC virus and want to move off of that. It hasn't really moved into a first-line position, even though the FDA approved it as a first-line drug. That and the fact that it costs $50,000.